with the push towards getting people out the door, out of the hospital as fast as possible, you knew we'd get here, right? Same-day discharge compared to overnight hospitalization after uncomplicated PCI. This is a systematic review and meta-analysis. I am with Dr. Olivier Bertrand, MD, PhD, and interventional cardiologist at the Quebec Heart-lung Institute. We're at ACC 13. First, thank you very much. At this particular meeting, what are you talking about in terms of the safety and the data regarding same-day discharge versus overnight staying?
Okay, thank you for the attention. As you know, same-day discharge after uncomplicated PCI has been practiced over the world for more than 15 years, 20 years. And we did perform a randomized study called the EASY trial a few years ago. It didn't have so much attention in the US because for many reasons there were more negative incentives to keep the patient overnight hospitalization. So the first question is obviously we try to see, okay, can we reassure people, hospital administrators about the safety? So we collect data from 13 studies, 5 randomized trials, 8 observational studies, collecting data over more than 100,000 patients, and looking at all the, first of all, the total complication rate, the MACE rate, so the major adverse cardiovascular event, and the rehospitalization within 30 days. And we basically, with some limitations in terms of statistical power, we basically show it's about the same kind of result. So the issue about is it safe? Well, I think that for at least elective patients, we can be basically reassured that it's a safe practice. And whatever the type of complication you are looking at, either ischemic or bleeding complications, well, there is no penalty to discharge patient on the same day after 4 to 6 hours after the PCI. Obviously, we always talk about uncomplicated PCI, so we are not saying that we should discharge every patient and it's an obligation for hospitals now to discharge patients. But what we are saying is that if the patient is coming in the hospital on his feet and he has an uncomplicated PCI, by the way, we also know that radial PCI provide a much better safety approach than the standard femoral approach. And then the patient, when the hemostasis is completed, can go home safely. And most of the patients prefer it.
Now, in this particular paper, you're taking a look at the same-day discharge compared to overnight hospitalization after uncomplicated PCI. Is this in acute as well as in stable ischemia? In other words, elective PCI?
Well, that's obviously a very important question. And, again, we are based on analysis over more than 20 years of practice, especially in Europe when it's been routine. So there is not that much studies to evaluate anymore. But when we try to do it systematically, obviously most of the studies include patients at lower risk. So we're talking about elective PCI. In my institution and in some institution and in previous studies, we also include some patients with moderate high-risk acute coronary syndrome, so patient with non-STEMI, for example. And we again show that when the procedures are uncomplicated and when you have a perfect result, there is no point to keep the patient lying on a bed overnight. That's the whole principle.
Well, after years, you've become more comfortable pushing people out the door, and here in this country, we're still getting our feet wet with that.
Yes, but as you know, there is many leaders like Ian Gilchrist in Pennsylvania or Sunil Rao at Duke, which have been also starting to push a lot. And there are many barriers. This is a change of practice. So it's always difficult from the physician perspective, nurse perspective, patient perspective. So if we talk about the patient perspective, they have to be reassured. So it's always very important also to develop a very particular way of following the patient. For example, we recommend that a nurse or a physician assistant will call the patient the next day just to make sure, again, for example, if it's the radial, that there is no small hematoma and that the family is not anxious about something special or what. And second, that the patient is also taking his medication. Because one thing that we have been hearing a lot is that when you keep the patient, when you shorten the duration in the hospital, you don't have much time to teach the patient about the requirement to take his antiplatelet medication on other medication. We all know that it's not because you have a stent that you are cured. The patient have to understand that there is a chronic disease.
So quick follow-up. You don't want to wait 6 weeks.
No. That's the two ways that we have been trying to do it. First, it's like what I call the safety net. When you had the next day call to reassure about the procedures, right. And then we should also manage to perhaps develop, like we could call PCI clinic, when you just take the patient back and then you explain about the risk factors, modification, rehab centers, and how you can modify and lower the risk of having other events or repeat procedures. Because one thing that we learn, you may get a patient which is in 55, he has an acute coronary syndrome during the night, and he will be up at 9 a.m. and he will have a proximal LED fixed with a stent. And at 4 p.m. we're going to say you can go home and then you can exercise tomorrow. So then patient will start to say, oh, is that it to have just in mind now? I can have 10 in my life. So there is a danger that if you accelerate without control or without developing the program, that you may have also some unexpected consequences which are not beneficial for patients, obviously.
So for more information from ACC 13, please see CardioSource World News. I'm Executive Editor Rick McGuire.